Hello, everyone. Welcome to today's live broadcast, Clinical Whole Genome Sequencing in a Healthy Population. I'm Christina Jewell of Labroots, and I'll be your moderator for today's event. Today's educational seminar is presented by Labroots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. For more information, go to www.labroots.com. We have a few important announcements before we begin. This webcast is designed to be interactive, and we encourage you to ask questions during the event. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to answer as many questions as we can. You can enlarge the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window, or submit your problem through the green Q&A button on the lower left. I would now like to introduce today's speaker, Erica Ramos. Erica Ramos, MS LCGC, is the clinical head for Illumina's Healthy Genome Initiatives team and president-elect for the National Society of Genetic Counselors, the leading professional organization for genetic counselors, more than 3,500 members strong. After 11 years in patient care, Ms. Ramos joined the Illumina in the Clinical Services Laboratory, where she managed the clinical group that implemented interpretation and reporting processes for clinical whole genome sequencing, cWGS. Currently, she focuses on advancing the use of cWGS by providing access and education to healthy individuals through the Understand Your Genome program, My Genome Visualization Software, and other collaborations. Her focus on education extends to genetic counseling students, and she is adjunct professor in the genetic counseling department at Augustana University. She also tweets from @eRamosSD about genomics and genetic counseling, music, travel, and other interests. I will now turn the presentation over to Ms. Erica Ramos.
Thank you, Christina. It's really a pleasure to talk to everyone about this topic today. As a clinical genetic counselor, my whole world in genetic counseling really started when genetics was mostly being used to affect people who were already ill. And one of the really exciting things that we have the opportunity to do now is actually to start taking care of people when they're healthy and start predicting what diseases they may be at risk for. And we've started this program through our company Illumina called Understand Your Genome, and we've now sequenced through this over 1,300 people. So we have a lot of really great information about what this means in a healthy population, and that's what I'd like to share with you all today. As I mentioned, when we think about clinical genetics and genetic counseling, usually we think about kids like this. And this is really how genetics and genomics got started, and still today is its most common use. This was actually the first story of a child who was helped by something we call whole exome sequencing, which is a technique that looks at just the coding regions of a particular genome. This little boy's name is Nick Volker, and he was, as you can probably tell, a very, very sick little boy. This picture was taken when he was about 5 years old. He had an extremely severe form of inflammatory bowel disease. In just 2 years, more than 100 trips to the operating room, and had spent more than 300 days in the hospital by the time he was 5 years old in 2009. One of the more critical things about this story, particularly from our healthcare perspective, is that by the time he was just 5, they had spent more than $2 million on his healthcare and were getting nowhere. He was going to die. There was no question. And his physician had called up a really phenomenal geneticist named Howard Jacob at the Medical College of Wisconsin and said, I keep hearing about all this whole genome sequencing stuff. Is there any way that this technology can help Nick? Because his doctor knew this had to be something genetic. It was such a rare form of inflammatory bowel disease. It was so severe, and to see it in such a young child just didn't make sense. Fortunately for Nick, Howard took on the challenge, and along with his team, they sequenced Nick's exome. And they were actually the first group to do whole exome sequencing. At the time, the cost was over $70,000 just to look at Nick's exome. And that's only about 1 to 2% of his entire genome. This is all the coding regions of the genome. When they looked at Nick's exome, they had over 16,000 candidates. for the genetic variant that might be causing his disease. And his team actually had to build tools so that they could analyze this data. They did such a great job that they were able to narrow it down to one. And that one very specific change is a change in a gene called XIAP. This particular genetic change was just one letter in Nick's genome. But this particular genetic change had never been seen in anybody but Nick and Nick's mom. This happens to be on the X chromosome, so it's an X-linked genetic disorder. And even still to this day, to the best of my knowledge, Nick and his mom are the only people that we've ever identified that have this particular genetic change. So this was Nick then, and this is Nick now. Nick's life was saved by whole exome sequencing and Howard's team. When they diagnosed this particular mutation in the XIAP gene, they diagnosed Nick with a disease that was actually treatable with a bone marrow transplant. And after a bone marrow transplant and a long uphill battle to recover, Nick is now 9 years old and doing really, really well. This was actually Nick at the opening of the Hudson Alpha Smith's Genomic Medicine Center, which is where Howard Jacob and his team are now. And if you're interested more in Nick's story, which I guarantee is worth the read, there were two journalists that published a Pulitzer Prize winning story about Nick in the Milwaukee Journal Sentinel, and it's now a book that's available. Really, really phenomenal read for anybody who's interested in how genomics started. So the other thing that you may have noticed is that this was us just 6 years ago or so. We haven't, it's been a long uphill climb, but we've made an incredible amount of progress in that time. And now whole exome sequencing that Nick has is something that's offered fairly standardly to a lot of kids with undiagnosable genetic diseases. So the next step is, how do we use this in healthy people? This is just a map showing our what we call Understand Your Genome program. And we started this program in 2012. Since that time, as I mentioned, we've sequenced more than 1,300 healthy individuals. I bring this up to show you that we've sequenced people all over the world of different races, ethnicities, although as I'll show later, there's still a pretty consistent trend in the people that we've sequenced. And up until now, this is actually the largest cohort of individuals that we're aware of that have had whole genome sequencing done in a clinical laboratory setting with return of results. This particular test that they have is something we call our predisposition screen, and it looks at more than 1,600 different genes for about 1,200 different disorders and a pharmacogenomics panel. So that gives you an idea of the scope of the types of things that we've been looking for in this population. Now, obviously, that's not us doing interpretation on a whole genome, and we still have a long way to go before we're able to really get all of the information that we want out of the genome. But we have learned a lot of lessons from sequencing 1,300 healthy people, and those are some of the things that I want to share with you today, along with some of the other advances that are happening in whole genome sequencing. So one of the key messages that I learned, and I was honestly a little bit surprised by, was that sequencing healthy people is accelerating discovery in multiple areas, including in rare disease. As I mentioned with Nick, what we're really doing with rare disease analysis is to try to find the 1 or 2 variations in the genome that are causing an individual's disease. Now, we have more than 3 billion base pairs in our genome. So we're looking for 1 to 2 of those that are actually causing problems. And that's essentially the quintessential needle in a haystack problem. So the more information we have about what's normal in a genome, the more the benefits are to finding those conditions in a rare disease population. The more it helps us rule things out faster. If a genetic variant is actually very prevalent in the general population, it's much easier for scientists to say, nope, this is not what's causing that very rare disorder. So the more information we gather about what's normal in a genome, the better job we can do in analyzing rare disease cases like what we did with Nick. The other really interesting area that we're moving into is looking at people who actually have genetic variants that should have genetic disease. This picture is from a really fantastic article by Ed Young that was in The Atlantic last year. And this was about a study called the Resilience Project out of Mount Sinai. And this particular project was looking specifically for people who seem to have genetic mutations that should cause disease. So one really common example of that is in the cystic fibrosis gene, CFTR. The most common known pathogenic mutation in that particular gene is the delta F508 mutation. And if you have 2 copies of delta F508, traditional medicine and traditional genetics would say you absolutely should have cystic fibrosis. This study actually found somebody who had those 2 copies but didn't seem to have the disease. And they found several other people that seemed to have these issues. So what does that tell us? Well, first of all, it's telling us that we actually have a little bit of selection bias when we've done genetic testing. When you think of the cost of genetic testing and how it was implemented, we didn't go out and test everyone in the world for cystic fibrosis. We only tested the people who showed symptoms, and we tested their family members. So now that we have the ability to go out and test a lot of people, what we're learning is that maybe the spectrum of cystic fibrosis is much broader than we thought it was before. Additionally, these individuals might have things in their genome that are actually keeping them from getting cystic fibrosis. So these would be protective variants that actually could be treatment targets and actually benefit people with cystic fibrosis or with other diseases. Another very, very common genetic disorder is sickle cell disease. So sickle cell disease occurs in about 1 in 400 African Americans, and about 1 in 10 African Americans are carriers for that particular condition. Recently, there were some studies that looked and again saw people that had these 2 sickle cell mutations and should have the disease. And what they found was they actually had a 3rd mutation that affected the production of fetal hemoglobin. And because of that 3rd mutation, they never went on to develop full-blown sickle cell disease. Now, that mutation is now a target and something that researchers are looking at to see if they can treat sickle cell disease in that way instead of the way that we've traditionally been treating it. So this is great. We're going to sequence all these healthy people and try to get answers for rare disease and even some common rare diseases. But how does that benefit the healthy? Well, this is really a cyclical relationship. If we sequence a lot of people and we learn what mutations might be beneficial and what might help to prevent those individuals from getting the genetic diseases that we thought we knew really well, we can also take genetic diseases that are rare and look at how they might tie to the healthy. So this is one example. If you look at the X-ray of the individual on the left, it's from an individual that has a disease called osteopetrosis, so an over-density of bone. On the right is something that we're more familiar with, which is osteoporosis, which is a lack of density in the bone. Now, you can imagine that if there's a genetic change that helps to make bones more dense than they should be, you could probably start taking information about that gene or that genetic change and start to create therapies for osteoporosis based on that information. So it really works in both directions. The more we learn about rare disease by testing the healthy, the more we benefit both. The more we learn about healthy people, we benefit the rare. Now, how do we do this? Well, one example is by donating our genetic information. And there's a really fantastic resource that was created over the last several years called ClinVar. And this is currently the largest repository of genetic variants that also has information about whether a clinical lab thinks that variant is related to disease. So when we call a variant pathogenic, for instance, we're saying that we have good confidence that that's related to a disease. And ClinVar is one of the first that's actually tied the variant information to these interpretations of pathogenic, benign, et cetera. Through our 1,300 people that we've tested in the UIG program, our lab has actually donated more than 95,000 variants to ClinVar, which is pretty huge. So, and 99% of those that the lab has donated came from our UIG participants. Now, as I mentioned, this database is from all clinical labs. So a lot of the information in that database comes from sick people. And now this is a contribution that helps us to balance out the sick and the healthy. What they have right now is more than 200,000 variants that have evidence. And when we say that something has evidence, we mean that it has the information that the lab used to call it pathogenic or a variant of unknown significance or benign. Our particular donation added more than 50,000 variants to that database. So again, sequencing even 1,300 healthy people is adding huge amounts of data to these really critical databases that help to diagnose sick kids and help labs to do a better job at what they do. But the really powerful thing starts to come when we look even bigger. So there's a really phenomenal researcher at the Broad Institute in Boston named Dan MacArthur, and again, a great article by Ed Young in The Atlantic. One of the comments that Dan made in this article about building these big libraries of genetic information is that in an ideal world, you would compare all of a patient's variants against every individual who's ever been sequenced in the history of sequencing. Now, if you remember back to my needle in the haystack slide, that starts to make sense, right? So we need to figure out if that one or two variants that our sick person has are different than what we see in the general population. So ideally, you want to look at everybody else and see if they also have those genetic changes. The assumption being that if healthy people have them, it's probably not what's causing a very rare disease. But how many people does Dan mean when he says everybody who's ever been sequenced in the history of sequencing? Well, so far, that's not probably as high as we'd like. Just about 3 months ago, Dan's lab came out with an addition to their existing browser called Exact, and the new one is called Nomad. And these particular databases have about 126,000 exomes. So again, that's the coding regions of the genome, about 1 to 2% of the genome, and about 15,000 whole genome sequences. So right now, this is the biggest public database that's available to look to see what's in a particular genome. And the huge advantage here, and what we really get from Dan's types of databases, is something that we call allele frequencies. So what this tells us is how common is a particular variant in a particular population. That frequency of an allele is really critical to labs when they're trying to make assessments about whether something is related to disease or not. So you can imagine when these two databases are there, when you have this huge database that says how common a variant is in multiple different populations, and then you have a database that helps to tell you what other labs have seen, especially for these more rare variants, we're really creating a resource that every clinical lab out there can use to help to do a better job of interpreting genetic variation. So why is this important? Well, part of the limitations, and one of the things that people will push back on when we talk about sequencing a lot of people or sequencing healthy people, is that there's a lot of uncertainty in the genome. And that's 100% true. But there's really two things that I think are important to highlight around the uncertainty in the genome. The first is that this is absolutely not unique to genetics. This happens all the time, and the example we use a lot is in radiology. So as we develop new technology, new things, we learn new things. So this is actually an image from a brain MRI. And this is something called diffusion tensor imaging, which tracks the non-random movement of water molecules through the brain. This is considered a typical DTI image of the brain. And about 10 years ago now, I had an MRI, and this is what my DTI looked like. Now, you guys don't know this, but generally I'm a pretty highly functional adult, and this was a big surprise to the radiologist that had scanned me. And the reality is that if he didn't know who I was and that I didn't have any major brain injuries or anything like that, this would have been really, really concerning to him. So number one lesson is that we have to take all uncertainty in genetics and compare it to the uncertainty that we've used, how we've resolved uncertainty in other fields. In this particular case, and what we always encourage in genetics, is really to merge the genetic information or the technical information with the clinical. So in this case, the radiologist talked to me and said, hey, something looks a little funny on your imaging, tell me about your history. And I told him that when I was younger, I had a concussion, and from his perspective, that fully explained this particular finding. We have to do the same thing with genetics. We can't just look at it in a bubble. We have to tie it to people's clinical findings and to other tests. But the other thing to know is that we will get over that. So the more people we test, the more information we have, and the better job we're able to do with that. One of the big historical concerns that goes along with this is that patients are not going to be able to deal with this level of uncertainty. And again, what I can tell you from my personal experience is that it's much less problematic for us as patients than it is for us as clinicians. As a genetic counselor, I would absolutely worry about my patient's ability to understand what we call a variant of uncertain significance, seeing something in their genetic makeup that we just don't know what to do with. But in radiology and as a patient, I was perfectly comfortable that I'm a healthy individual. This clearly isn't doing anything to me so far, so it's probably okay. Now, this is going to become important as we start launching some of these big precision medicine initiatives that you probably have been hearing about and will continue to hear about. And a bit over a year ago, President Obama announced what we call the Precision Medicine Initiative, or now something that's referred to as All of Us. And the reason this is so critical is that this particular program is really meant to build the largest database in the United States of information of our participants that contributes to personalized medicine. So that's not just going to be genetics, that's going to be people's Fitbits, that's going to be their medical records, that's going to be a lot of information about their health so that that data can be mined by researchers and can be used to advance the concepts of personalized or precision medicine. Now, some of the things that I just mentioned, Fitbit data, healthcare records, genetic data, we think of that as pretty sensitive stuff, and we were really curious from our perspective on how likely a broad population was to accept that. So here in San Diego, we partnered with what's called the San Diego Blood Bank to work on a project on a community genomics initiative that really brought together the altruism of a blood bank population with the innovation of genetic technology. So some of you may know our San Diego Chargers seem to have migrated a bit up north now. But historically, the Chargers have had an annual blood drive every year right before Thanksgiving. And it's the biggest blood drive, one of the biggest blood drives in the world. It's actually won the Guinness World Record for largest blood drive or most blood donated. And this has really been an institution in San Diego. So we thought it would be great to partner genomics education at this event with a test that actually looked at 70 blood donors to see if we could get blood donors to contribute genetic data, what type of data they might be interested in contributing, and really if we could even use blood centers as a good recruitment tool. The reason this is important is that our typical participant in whole genome sequencing or genomic studies right now tends to fall into a very narrow category. They are mostly male, they are mostly Caucasian, they are mostly well-educated, they are mostly wealthy. This is data that's based on a program that our Understand Your Genome participants participate in called PeopleSeek that's run out of Dr. Robert Green's group at Harvard. And this particular study is looking at lots of different initiatives that have done personal genome sequencing like UIG. And this is sort of what they're finding. So this was not all of their participants, but we see this trend pretty typically across other studies as well. So the issue here is that the more diversity we have in genomics, the better job we're going to do improving personalized and precision medicine for everybody. And part of the Precision Medicine Initiative, part of their charge, is actually to get a representative sampling of the population of the United States. And we know that this is not what the United States looks like. We need to do a much better job of recruiting people of different ethnicities, different education levels, in order to really hit that goal. So that's what we focused on as part of this pilot project that we did in collaboration with the San Diego Blood Bank. This particular graph, and I have many more on a lot of other characteristics, this happens to focus on race. What we did was we took the San Diego census and we sent out invitations to a huge group of blood donors and got more than 7,000 responses from people who were interested in participating in this type of study. So a really, really phenomenal response rate from a very engaged altruistic population, which wasn't surprising to us, but it was what we were hoping for. What you can see here is that we actually do have a really great representation of race. We did the same for education level, we did the same for income, we split it up by gender, by age. So we were able to really select a very representative sampling of San Diego. And if anything, we were able to over-select for populations that are typically underrepresented. So more women, more ethnicities and races that tend to be underrepresented. So what did we find? We found that our concern of whether they would provide this information or not was fortunately probably not an issue. What they were, more than 60% of people were willing to provide information from their Fitbit, information about their lifestyle, biological samples, genetic data, and they were willing to commit to contribute survey data. The only things that were a little bit lower than that was information from their health record, which is kind of understandable. There's obviously a lot of concern about sharing that information, and information from their social media accounts, which we all thought was sort of interesting considering how much people put out on social media. So what we were able to show was that when we start looking at how we can engage with a healthy population, number one is that partnering with great organizations that are trusted in a community is very valuable. But overall, people of all different races, ages, economic backgrounds are really willing to participate. They understand genomics is important and they want to contribute. So if we can reach them in the right ways, we have a really good shot of getting a very successful and diverse study in the PMI. So what are some of the other things that we learned? One of our biggest lessons, and this was something that I think is the most critical as we move forward in implementing this in healthcare, is that we actually find a lot in a genome that we presume to be healthy. There's a lot of people who now will not say there's a healthy genome, and I think I would probably agree with that, because we know that all of us have things in our family, we have certain risks for diseases. And there's a lot of different places that this can actually be beneficial before someone gets sick or before they start to take a medication. So this is a graph of a group of UIG participants that came from the Mayo Clinic in Florida. And what you can see across the bottom are the numbers of our individual participants, so 1 through 39. And each of these colored bars actually represents for one common drug where that particular individual had a different than typical metabolism for that medication. So in this first column, you can see 4 colored blocks. That particular individual had a different than typical metabolism for clopidogrel, also known as Plavix, for tricyclic antidepressants, and for 2 things that impact warfarin metabolism. Now, this is why pharmacogenetics is kind of considered the low-lying fruit. These are very, very common drugs that are prescribed. Now, that doesn't mean that these people were taking these medications, but we know that they're something that they may plan to take at some time in the future. And certainly with warfarin, what often happens is they don't know they're going to take that information. What will come is that somebody will get a blood clot, and the first medication that they are typically given to treat that blood clot is warfarin. Now, we also have the ability with the genome to help to start figuring out who's higher risk for those blood clots. And so that was the second thing that we looked at with these particular individuals. These purple stars at the top of bar 5 and bar 27, those purple stars indicate people who have a mutation called factor V Leiden. And the factor V Leiden mutation is something that can increase the chance that somebody will develop a blood clot in their lifetime. It's not a huge increase, but it is somewhat significant, particularly when it's in combination with other risk factors like birth control pills or smoking. So not only are these 2 individuals people who are more likely to get blood clots than somebody in the general population, but they're also the people who have different than typical metabolisms for warfarin. So these are people who would benefit from potentially a different starting dose of warfarin to have a lower rate of complications or of inefficacious dosing. So this is one of the big advantages of whole genome sequencing or testing genomics in a healthy person. It's not just getting the pharmacogenomics data, it's being able to look at other risk factors and tying those two pieces together. Now, it's not just about those things, and certainly not everybody will have a response for some of these different things, but sometimes there's actually even more significant things that come up. So in our San Diego blood bank study, one of the really neat things that we were able to do was to partner with a group called Informed DNA to offer genetic counseling and return of results to each of our participants. So we collected a really detailed family history, and we were also able to talk a lot to them about their results and get feedback about what their experience was and what they plan to do moving forward. This particular case was a young male. When he first consented to the study, he hadn't talked about any specific family history, and he didn't report anything too significant to the genetic counselor after his results were available. And when he was asked why he decided to participate, he said that the San Diego Blood Bank hassles him pretty regularly about his blood type, so he thought, why not? Now, that's obviously not the reason that most people decide to pursue genetic testing. It doesn't tend to be a just because I wanted to or just because sort of thing. So this was kind of interesting because he really wasn't expecting to find much, and he really wasn't going into the test trying to gather information. So what did we find? One of the things that we found was a likely pathogenic variant in a gene that we know can increase risk for cardiomyopathy. This particular gene impacts risk for ARVC, which is arrhythmogenic right ventricular cardiomyopathy. For those who may not be as familiar, this particular form of cardiomyopathy can be related to sudden death. And so it's really important for us to be aware of these types of risks before an individual has a cardiac event. The other thing we found was that he's a carrier for that common cystic fibrosis variant that I mentioned before, Delta F508. So when we looked at his family tree, he's the square down there, the 26-year-old with the arrow pointing to him. It was sort of interesting because ARVC is actually what we call a dominant genetic disease. And that means that oftentimes there's a family history. When we looked at his family, though, it actually makes sense. If you see the brackets around his mother, so the 49-year-old, that means that she was adopted. So he actually did not have any information about his mother's side of the family. We also know that cardiomyopathy is not fully penetrant. So it is possible to have a genetic variant that could cause the disease, but not ever develop it. And that risk for developing disease does go up with age. So his mom's still fairly young. It may be that over time she would have a risk to develop that particular disease, but hasn't yet. So what have we learned from just this one genome sequence? We've learned that this particular individual has this risk for cardiomyopathy himself, and most likely he inherited that from his mother, although she would need to be tested to confirm that. So if we confirm that, we've essentially been able to identify two people that almost certainly have an increased risk of cardiomyopathy and as a result of sudden cardiac death. We also know that his brother has a 50% chance of inheriting that cardiomyopathy variant. So he also needs to be tested. And we could then identify up to 3 people in this family that have that significant risk. His brother also has a 50% chance of carrying that cystic fibrosis variant. So where that plays in is if they decide to have children. Their children also have a chance to inherit both of those variants. And if either of them have a child with a woman who's a carrier for cystic fibrosis, their children not only could be at risk for cardiomyopathy, but also for cystic fibrosis. So how is he feeling and what is he going to do next? He certainly did say that the ARVC was unexpected, but when he had originally had the consenting session, the genetic counselor who consented him had talked to him about the fact that his mother was adopted and that when we do find surprises in the family history or surprises in the genomic information that are pretty big things, it tends to be because we don't know part of the family history. So that good consenting process and really making sure that he knew what to expect in advance was really valuable to him. And since he had time to think about it and know that there was something that might come up because of his mother's unknown family history, he was doing okay with this information. He said he's going to get a cardiologist, and he did say that he would talk to his family, and he did understand that both his mother and his brother were potentially at risk to have this same genetic variant. So this is really one of the things that we've recognized. And of course, this is just one example. What I can tell you, though, is this is not atypical for our Understand Your Genome participants. In our 70 San Diego Blood Bank participants, we actually had another gentleman who we diagnosed as having a hereditary form of arrhythmia. And not only did he report a history of arrhythmia, but he reported that his granddaughter, a young girl in her teens, was actually recently put on exercise restrictions and had some sort of heart thing. So in 70 people that we tested completely randomly from the population in San Diego, 2 of those 70 people had pretty important findings that impacted not only them but their family members. And that's just one set of examples. The 2 genes that I mentioned that related to the cardiomyopathy and the arrhythmia are part of a set of genes that we call the ACMG 56. So a few years ago, the American College of Medical Genetics and Genomics came out with a list of 56 genes. And what they said was that if you're going to do whole genome or whole exome sequencing for any reason, rare disease or for healthy people, you should always look for these 56 genes. And that's because these are what we call highly actionable genes. So these are genes like BRCA1 and 2 that predispose for hereditary breast and ovarian cancer. The genes related to Lynch syndrome, which is a hereditary form of colon, endometrial, ovarian, and other cancers, and cardiomyopathies and hereditary arrhythmias, along with some other disorders. We didn't know how common these things were going to be. When we look at them historically and what we see in the population, they don't seem that common by themselves. But what we actually found in our lab was that about 2.5% of our healthy people actually had known pathogenic mutations in one of these 56 genes. These are almost all what we call dominant diseases, again, genes that if you have even one pathogenic variant, you might develop the disease. And your first-degree relatives, so parents, siblings, children, also have a 50% chance to develop those same conditions. So these are really, really high impact variants for us to find, and we're actually finding them in about 1 in 40 people in the general population. So as a genetic counselor, that was actually really shocking to me. And it's not just in our lab that we're finding this. This is really pretty consistent that other groups are finding as well. So what does all this lead us to? I think the really exciting thing about what might come next is that the more data we collect in a healthy population, the more we have the ability to inform things around population screening. So back in 2014, Dr. Mary Claire King, who is incredibly well known for being one of the discoverers of the BRCA1 and BRCA2 hereditary cancer genes, Dr. King was awarded the Lasker Award. And as part of the Lasker Award, she published this particular paper and really made the case for screening everybody for BRCA1 and BRCA2. Now, historically, we've had very specific groups of people that we offer this genetic testing to. And a lot of that rationale was, number one, it's not likely to find a mutation if you don't fit into one of these predefined categories. And number two, if you don't fit into one of those previously defined categories, the odds of finding one of those uncertain results exceeds the odds of finding something significant. What she says in this paper, though, is that in the United States, the number of BRCA1 and BRCA2 carriers is about 1 in 300 to 1 in 500 people. Now, this particular case, she focused on women because they're the highest risk of developing the cancers related to these genes. So that means that in the US, there are somewhere between 250,000 to 415,000 adult women that have BRCA1 or 2 mutations, and for whom breast and ovarian cancer is both highly likely and potentially preventable. So that's a pretty big number. And what Dr. King was able to demonstrate was that even when we did this testing in an unselected population, these individuals, so no known family history, no personal history, these women were still very high risk for breast cancer. There were a couple of different groups. So Hudson Alpha, where Dr. Jacob is one, and a lab called Council in San Francisco was another that sort of took her challenge on and said, we're going to offer testing for these genes to everyone so we can learn more about what these look like in a general population. And the really interesting thing that they found was that about 50%, so half of the people who had these pathogenic mutations in these very, very important hereditary cancer genes did not fall into one of our previously defined groups. They didn't have the personal or family history that genetic counselors like me or others would have used to identify them as high risk, and they very likely could have developed cancer without ever knowing they were BRCA positive. So this to me was really impactful. If we're missing 50% of these women because of our criteria, then that's pretty strong evidence to me that we should start thinking about testing everybody. And that's Dr. King's recommendation. Her recommendation, which she's been out talking about regularly, is that every woman aged 30 and older should be offered hereditary testing for BRCA1 and BRCA2, and that any pathogenic result be returned to those women. So this made me start thinking about our ACMG 56 findings. So there are about 238 million adults in the US. 1 in 40 people, so 2.5% that have those ACMG 56 variants, that's almost 6 million adults in the US. So that's 6 million of us that are walking around with genetic variants that could cause hereditary cancer risk, hereditary cardiac disease risk, and other genetic diseases. So that was a pretty impactful number to me as well. And I think that's one of the things that we should be thinking about as we start to move this forward. There is a lot of potential for benefit. Now, again, one of the arguments that's come up around the 56 ACMG genes is that we don't know what the penetrance is if there's not a family history of these disorders. So when we talk about penetrance, again, with genetic diseases, we're talking about how likely it is that if you have a pathogenic variant, you will get the disease. And the suspicion was that potentially people who did not have a family history would have a variant that has lower penetrance than people who did have a family history, which is not an unreasonable hypothesis. So fortunately, Dr. Robert Green at Harvard tested this. And he actually went back and looked at 2 big studies. One was the Framingham Heart Study and one was the Jackson Heart Study. So this was about 462 European Americans in the Framingham study and about 3,000 African Americans in the Jackson Heart Study. What they did was actually do whole exome sequencing on all of the samples from individuals in these studies. And they have a lot of history about these individuals and their health status. So they looked at those 56 genes without matching them to their health status or their clinical data, and looked to see how many of those individuals had mutations in these genes, and then how many had diseases that were tied to that. So what you can see in this particular table is that when they looked at individuals who carried variants in the ACMG genes, the number of conditions that were related to these genes far exceeded what they observed, far exceeded what would be expected by the population risk alone. So they took cardiovascular history into consideration, certainly because these were both heart studies, but they were heart studies of people that were generally healthy. So when they looked, for instance, at the Framingham study, they found 2 individuals that had mutations in hereditary cancer genes, and both of those individuals had actually gone on to develop cancer. So what this is telling us is even when people are not selected because of their family history, it seems that the penetrance of these particular genes is still fairly strong and warrants potential testing. So as we move forward into the world of genomic testing, I think there's no question that we're going to start seeing this more and more in healthy individuals. Fortunately, we're going to take some of the uncertainty we have now. We're going to do studies like the study that we did with the blood bank and the study Robert Green is doing with PeopleSeq, and then with this data around penetrance. And we're going to learn more so that we can apply it in the best possible way. So the message that I want to leave you with is that this is a process. And not only that, but one of the things that we need to do is to not think of whole genome sequencing as a test. In medicine, we tend to think of tests, or most of our tests that we run are one-time events. And whole genome sequencing is really a resource. It's something that we should be able to continue to go back to as we learn more, as our knowledge base changes, and as new things happen for the individuals who are sequenced so that we can ask better questions and get better answers. Thank you.
Thank you, Ms. Ramos, for that informative presentation. Now, before we get started on the question and answer session, I would like to remind our audience how to submit questions. You can submit questions by typing them in the Q&A box, which can be found by clicking on the green Q&A button at the lower left of the presentation window. We'll try to get to as many questions as we can. Our first question is, what do professional organizations say about sequencing healthy people?
So currently there are a couple different recommendations that have come out by societies like the National Society of Genetic Counselors and the American College of Medical Genetics and Genomics. At this point, there's nothing that says that healthy people shouldn't consider getting sequencing, and that really adults should decide for themselves if getting testing is something that they're interested in. However, what they do recommend is that that testing be done in the context of genetic counseling, both before the testing and after the testing. So really making sure those individuals are well educated about the benefits and the limitations of testing, about any risks that there may be for things like insurance discrimination, any concerns that they may have about sharing that data with family members, and really if there's anything that they may or may not want to know. So right now it's something that isn't recommended per se as part of normal health care, but the professional societies really just suggest that if people are pursuing it, they get the right services and good genetic counseling to go along with it.
Our next question is this type of testing covered by insurance?
So genetic testing in general is often covered by insurance if there's a personal or family history of the disease that is being looked at. So for instance, in cases of whole genome sequencing or whole exome sequencing in sick kids, or sick adults for that matter, it is often covered by insurance, although the amount of coverage may differ, and that's one of the reasons that we recommend talking to genetic counselors to help figure out what testing will be covered and how much out-of-pocket expense patients might have. Doing this type of testing in a healthy population is not typically covered. So that's one of the questions around the testing that Mary Claire King is promoting. And one of the concerns is that if you're a young, healthy person with no family history of cancer, your insurance isn't going to pay for testing. The advantage, though, is that now that the sequencing technology is getting less expensive and more people are doing this type of testing, historically there was one lab that did BRCA testing, and that testing cost about $4,000. Now there are clinical labs that offer testing for this and other genes at a cost of about $250. So it's now coming to the point where, at least in some cases, a healthy person can access this type of testing without the big out-of-pocket expense.
Thank you. We have time for one last question. When do you think it will be common for everyone to get genome sequencing as part of their healthcare?
So I think we're still a few years off from that. I think the estimates that we've seen pretty frequently fall in about the 5 to 10 year range. And that's, I don't think, maybe when the majority of people will start doing it, but certainly where it will start to be more and more common. And as importantly, we'll have doctors that are educated about how this testing can be used. We'll have healthcare systems and technology systems that can make it valuable. And so I think that within the next 5 to 10 years, we'll see a lot more healthy people with genetic information in their records, pharmacogenomic information before they get prescribed drugs, things along those lines.
I'd like to once again thank Ms. Erica Ramos for her presentation. Ms. Ramos, do you have any final comments for our audience?
Just that I appreciate you all taking the time to learn a little bit more about this topic.
Thank you again, Ms. Ramos. I'd also like to thank our sponsor, Labroots, for making today's educational webcast possible. Today's webcast will be available for on-demand viewing through May 22nd, 2017. You will receive an email from Labroots alerting you when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. Thank you for joining us, and we hope to see you next time. Goodbye.